right. Well, good morning, good afternoon, good evening, everybody. Thank you so much for joining us from everywhere in the world where you may be today for our final session of our complex lower extremity trauma course. It's really a pleasure to have done this over the last 4 weeks with all of you, and we really do appreciate you joining us for our final session today. Next slide, please, Emily. So today, as you guys all know, we will be talking about soft tissue coverage and flaps, and I'm really pleased today because we not only have a bunch of orthopedic surgeons on the line, but some wonderful faculty representing the great field of plastic surgery. And this course, this session in particular represents a wonderful intersection of our two specialties and a collaboration that is so important for patient care all around the world. So thank you so much for being part of that, faculty and all of you who are present today. So just as usual, a couple of reminders today with Zoom. If you can, keep your microphone muted while you're not speaking, that would be helpful. And we do also have translated captions available. If you follow these instructions by clicking on Show Caption, you can turn on the captions in your language if English happens to not be your first language. So just to reiterate, as always, our course objectives are always the same. First and foremost, to improve participants' knowledge of lower extremity trauma management. Second, we hope to foster this international discussion and provide practical advice to surgeons who are working in resource-limited settings. And then third, to motivate and support the younger generations of surgeons globally. So I'm Kiran Agarwal-Harding. I'm an orthopedic trauma surgeon here in Boston, the director of the Harvard Global Orthopedics Collaborative, and I'm joined by one of our exceptional residents here at Harvard, Elise Berlenberg, who's going to be leading the session moderation today. And then I have to thank our incredible HGOC and SONA Global organizing team. This incredible team of students and residents has been instrumental to orchestrating this incredible organization and conference. So I cannot say thank you enough to this incredible team who made all this happen. So our agenda today, we're going to have a guest lecture from Dr. Saad Ilyas, who's coming to us from Pakistan. And then we're going to jump right into the case presentations, first by Dr. Sushant, and then Dr. Fasi, next by Dr. Kawemi, and then Dr. Arsen. And we have some fantastic case discussants who are joining us today. Dr. Andrea, Dr. Andrew, Dr. James, Dr. Jack, Dr. K-Rod, and Dr. Lydia, and Dr. Mehti and Dr. Paul, joining us from all around the world. And Dr. Pierre-Marie and Dr. Sammy, as he goes by, will be joining us and providing some commentary as we go through the cases and also the presentation from Dr. Ilyas. So here's our agenda, and without further ado, I think we're at the end of my introduction. Dr. Ilyas, I'll turn the floor over to you. Thank you so much, everybody, for joining us today.
Thank you, Dr. Kiran, for the opportunity. Since I have limited time, I'll just jump straight to my talk. Can you all see the slide?
We can see the slide, but not full screen yet.
Yeah, now it is.
Yeah, go ahead.
Yeah. So today I'll be talking about role of distraction histiogenesis for management of soft tissue defects and scars. So typically we keep on referring to the term distraction osteogenesis whenever we talk about bone loss and things, but that's actually not entirely true. It's actually distraction histiogenesis, because during this process, not only the bone regenerates, skin, muscle, even the nerve and vascular structures, they also regenerate. So the appropriate term is distraction histiogenesis. And we all keep on saying about Ilizarov being a magical device, it creates magic. Well, distraction histiogenesis, it is actually the spell which causes this magic. So we'll be talking about it. So what happens whenever we do an osteotomy of the bone and we do gradual distraction, skin also reforms. It stimulates epidermal proliferation, which leads to increased amount of skin. So what happens when this process occurs and the stress is on the muscle? Actually, muscle is the most limiting factor when it comes to this process of distraction histogenesis, because muscle mainly responds by stretching without any cell proliferation or very minimal cellular proliferation. So usually this is a limiting factor whenever we're doing distraction histogenesis. And if you do a bit quicker distraction histogenesis on electron microscopy, it can be seen that there is malalignment of the sarcomeres because of this distraction. Well, blood vessels, they form, that's not a problem. Even the nerves, they regenerate. So these are not a real limiting factors. So Elizarov hypothesized that during the distraction phase, the blood flow increased not only on the regenerate but also around the regenerate and the distal part of the limb as well, and which has been proven by many technetium scintigraphy studies that the process of distraction histogenesis increases blood flow, significant increases, and this increase lasts for about 4 months. So I'm going to show you a few cases of different types and different pathologies so that you can get a better understanding of what conditions can be treated by this technique. So this is a 40-year-old male with open fracture of the tibia, about 14 centimeters of dead exposed bone with soft tissue defect. Obviously, the one option here is that you take out all this dead bone, you cover this defect by involving a plastic surgeon, and then later on you do reconstruction to the bone. The other option is that you do an osteotomy and do distraction histogenesis with segment transport like this, by applying an Ilizarov, doing a distal osteotomy and doing a segment transport. And as you can see, the bone moves with a soft tissue envelope and the defect is covered. Another case, a 20-year-old boy with massive bone loss in the femur of about 26 centimeters. And simultaneously, he also had a degloving injury over the heel of his foot. So one option is that you deal with the bone loss and you get a flap over the heel. But there's another option of, while you have applied an Ilizarov frame, doing a corticotomy. I'm not going to go into the details of this, and doing segment transport. Simultaneously, you can extend the assembly and you can gradually stretch the skin. Dr. Kin, can you see my cursor over here when I move it? Or
Yes, we can see it.
yeah, you can see here. But how do you do it? You see, you pass a very fine K wire, and over that you apply some non-absorbable loops of threads, and then you just gradually pull the skin down. And by doing this, you are elongating the skin, and then you simply are able to primarily close this skin, and you can get a proper healing here without any granulation tissue or scarring. So again, bone was also formed. And you can see here, like 2-3 years down the line, even though the knee is arthrodesed, but he's able to walk. His skin is fine. So another case. So these were the two cases in which I wanted to show how to use this process in dealing with when you have a soft tissue loss. So many a times you are dealing with problems in which there are soft tissue contractures or there are scars which need treatment. Like in a case like this is an 8-year-old boy who had a penetrating trauma to the dorsum of the foot, and this scar, the scar band over here, it led to this condition of abduction valgus deformity. You can see the foot is pronated. If you want to correct this, just by doing a soft tissue, a skin flap here, by removing the scar will not deal with it, because all the structures in this area are contracted. So the other option is that you can maybe remove this scar, get a flap, and then do some shortening on the medial side and to realign the foot, but that would lead to a severely shortened foot. So the other option is that I apply an Ilizorov here, and then you make a transverse incision like this, and it should be a very deep transverse incision, a full thickness incision, and then you gradually, slowly distract the forefoot into its normal alignment. You can see here, this is the device. This is the distraction motor device, which pushes the forefoot into adduction and plantar flexion. You can see here, the healing of the soft tissue is so quick because during this distraction process, the blood flow increases. And usually before you're able to get a proper alignment of the foot, the soft tissue has healed. And you can see here, the foot is now very much plantigrade. And I wanted to show this video because whenever I do this, there's a usual question is that the scar that you have created, it's an unhealthy thin scar, but that's not the case. You can see here, it's a very healthy, very thick tissue which is formed, which it is not a scar, it's skin. It's not blanching, it's very healthy, very thick. And with this process, you have also salvaged the ankle and you have able to achieve a plantigrade foot. So I'm going to show you another case. This is a very interesting case. This girl had a run over injury when she was 5 years of age, and upon presentation, she was 15. So because of that run over injury, she had a degloving injury to the distal part of the tibia, and later on, poor management resulted to this condition. So upon presentation, all of this was scarred. There was only a very narrow posteromedial area of normal skin. Other than that, it was all scar, and dorsum of the foot was tethered to the shin. So to correct this, you even though you need to make the foot plantigrade if you want a flap. So just by doing any soft tissue reconstruction is not enough. You need to deal with the bone, soft skin, and neurovascular structures as well. So this was the X-ray. You can see the ankle had already fused. So using that very narrow posteromedial corridor of the skin, I did an osteotomy here. This was the assembly that I used. And you can see here, these are the hinges. They are at the level of the osteotomy. My plan was to just start distracting anteriorly to try and make the foot go a plantigrade and see what happens with this scar. And you can see now, as the distraction started, this scarring started to pull the toes toward the shin. You can see distraction process started. Here you can see the newborn formation here, gradual opening at the bone. It's increasing. So as the distraction continued, the toes, even though the foot was correcting, but the toes were being pulled towards the tibia because this was all scarring. So now I made a transverse incision here, or full thickness transverse incision, and fixed the toes with the foot ring. And now started the distraction process. You can see here during the distraction process, my plan here was to get the foot plantigrade, and if needed, later do a graft or something, involve my plastic surgeon, but it was not needed. Before the foot was plantigrade, the skin here had already healed, as you can see over here, and I was able to get a nice plantigrade foot with very healthy skin covering the dorsal aspect of the foot as well, ankle as well. You can see the x-rays. So I'm going to show you one last case, then I'm going to finish. So this girl had bunion surgeries done on her. She's a 20-year-old girl. I have absolutely no idea what the surgeon did, but the result was that he tried to do an MTP fusion, and again there was some wound problems. Then there was resulted in massive bone loss, then shortening and very dense scarring over here. So in a case like this, you cannot do just by taking care of this scar will not deal with the issue, because you need to lengthen the first metatarsal. So these were the x-rays, as you can see over here, massive shortening of the metatarsals on both sides. So here in this case, I applied a simple rail fixator, did not do an osteotomy here, just distracted the soft tissues. As you can see here, just distracted the soft tissues, the scar and vessels and everything, to get the normal alignment of the big toe in comparison to the other toes. And then here I just made a full thickness in CN, put an iliac strut graft, fix it with a plate, and then remove the fixator. So this was the final result. So these were a few cases of, this was the x-ray. You can see plate, the strut graft in between. So this was briefly about the role of distraction histiogenesis in correcting soft tissue scars and defects. Thank you very much.
Thank you, Dr. Elias. Superb presentation. Do you mind going back to the slide with the extremely dorsiflex foot that you brought down into a neutral position? The initial x-rays, I think, are quite remarkable. Before we get into the discussion on this, I just wanted to tell all of our viewers that this lecture that you've just given, Dr. Elias, we will separate it from this full presentation and put it online for folks to view individually after the session, and we'll translate it into French and Spanish. And just on that same note, I want to mention that all of our educational curriculum is available for free online for folks who have registered for this conference. And we really are grateful to our partners, including OTA, who have co-branded and co-partnered for this conference. And for anybody who wants more access to content from folks like the OTA, please let us know in the chat and we can send you the way to register for the OTA. Mai, I don't know if you wanted to say a quick word on that before we dive into the discussion.
Thank you. The OTA is welcoming international members, so I'm gonna send a link to apply into the chat so you guys can join us and have access to more educational material with us. Thank you.
Thanks, Mai. Appreciate it. So, Dr. Elias, for this case, it seems to me that when you made the transverse incision to help with the soft tissues, it's healing by secondary intention, correct? It's not like the case of the calcaneal wound where you were actually distracting specifically the skin.
Yeah.
Yeah. So
exactly, because that's there I was trying to lengthen the skin. Here I just want to it to heal on its own. And the main concept is it's not just because if you just if you have a degloving injury, degloving wound, and you let it heal by secondary intention, it usually heals by a very pale, like unstable scar. Here it's not the case. During the distraction phase, the scar, if I would not want to call it a scar, it's actually skin that regenerates, because it's quite thick, it's not blanching, it's moving, it's very stable.
And do you feel that the secondary intention is accelerated in a sense because the blood supply?
Yeah, it does, because usually before that's usually the case. Before, during that I do it, I would do make an incision and start my correction process, and almost always before I have achieved correction, the wound heals. So it's very quick, it's very healthy. Yeah. So the patients are, yeah.
I'm sorry to interrupt, Dr. Elias. Go ahead, finish your thought.
Yeah, so and because I've never encountered any case in which this part of the wound it infected or nothing like that. So that's one of, I think that's the very most predictable thing that I can tell to the patients, because the incision that I'll be making, it will heal before the correction is made. So it's truly remarkable.
Yeah, it really, I mean, the cases that you presented are truly remarkable. I mean, unbelievable effort here that you've done to salvage these limbs. I wonder if you could comment on one, these are children that you're presenting. So perhaps their soft tissue envelope is more forgiving and more capable of regeneration. Does this same technique work on adults? And
The first case was actually 40 years of age, and this girl is 15. I would do it irrespective of the age, and I think it will work because, I've tried distraction histogenesis in a 70-year-old. Bone regeneration, obviously. If the bone is forming, why won't the soft tissue form?
yeah.
So that's my theory, because if the bone is regenerating even in a 70-year-old, the soft tissue should form as well.
And what about comorbidities like diabetes, smoking, things like that? Are these things?
Obviously, if I have a patient with uncontrolled diabetes and he's a smoker, I would not offer him limb salvage even if the soft tissue coverage is intact, because I know the bone is not going to form.
Yeah.
So I would not offer any limb salvage or of such sorts in a patient with uncontrolled diabetes, who's a smoker, has comorbidities like these.
I think that's a very important teaching point. Elise, please go ahead.
So, Dr. Ilias, these are some really impressive deformities that you corrected with these distraction histiogenesis. And I wonder, for you or any of the other panelists that might do distraction histiogenesis as part of their practice, this is quite a prolonged process where someone has to wear a frame for a long time. They have a higher risk of also developing wound infection because there are some open wounds, for example, with transverse incision. What kind of social counseling or rehabilitative counseling do you offer these patients, both in your patient selection, but also in helping them get through this recovery process?
Usually, whenever I'm applying a frame for a case like this, it's an attempt to do a limb salvage. So my first thing that I tell them is that, look, this is the only option that I have. The other option is an amputation. So if in my mind, I hope that the process is going to complete in 1 year, I would tell my patient that it's going to complete in 1.5 years. So they have to be ready for anything if there's a delayed union or anything. So they have to know, because the second case that I showed you with the 26 centimeter of bone loss, the frame was with the patient for about 2 years. So, but the good thing about Ilizarov is, because in almost most of the cases, the patient is allowed to weight bear. So that patient, because I did not want that case to take most of his time, even with the frame, he was a farmer by profession. Even with the frame, he was doing all of his activities in the farms. So that's the plus point with an Ilizarov, because the patients are weight bearing. And what I told you, because soft tissue, these scars that I deal with, I hardly ever encounter any problem because of the vascularity. The scars heal very quickly. So the main problem is pin track infections and these kind of things, which they have to deal with. Obviously, unfortunately, they have to take on and off antibiotics. Sometimes you need to take the patient into the OR, change a pin. You have to deal with these conditions.
Yeah, thank you very much, Dr. Elias. I was wondering, it seems like Dr. Abebe has a comment as well.
Yes, thank you for the presentation. Just for the sake of discussion, some points I want to raise are, when you say it's quickly heals, what are we talking about? What is the time frame that we're talking about? What does quick mean? You're making an I'm coming from a plastic point of view, so do forgive my critics here. But as you incise and you have that defect, what is a quick healing?
Like you
just
see, in a case like this of extreme calcaneovalgus foot, the wound was down to this size. Like it was down to this size in about 3 to 4 weeks. So in about second or third, because whenever I apply a frame, the patients have to come to me at a 2-weekly interval, at a fortnightly interval, they have to come to me. And usually in about third follow-up, I usually see that the wounds have healed. They heal pretty quickly.
Yeah, so this is also something we need to think about, comparing it to a skin graft or if it's available. And one other thing is, like, when you talk about stability or healthy scar or healthy healing in this case, what comes in is from the ages your keratinocytes are coming in, you're not regenerating a dermis here. So about stability of the scar, like, does it what are we talking about? Like, because the dermis is not there, it's just the epidermis that's coming in and closing this wound. What are your long-term follow-up in these patients? Like, do they break and heal? Is it like a very stable coverage that you get? Thank you.
So, this particular girl, I think I operated her about seven years ago. So she's doing very well, and I've never seen. This is the main reason I wanted to, because this is the main. This was the case. I just put this video just to show you. If you see this, the quality, just to show the quality of the skin. You see here, it's quite thick. It's not firm. It's not blenching. I've never with these cases encountered any soft tissue break or anything having any problems. And if you you have to understand it. If since we are doing a distraction, you cannot apply any graft while you're doing distraction to the patient, because if you want to apply a skin graft, if you want to do a flap, my understanding is that you need to immobilize it. So you cannot just make an NC and apply a graft and then keep on distracting, and you lose everything.
Certainly very challenging circumstances when you're doing that. And Dr. Mehti is an expert in dealing with burn contractures, and I think it's actually wonderful to hear her perspective on. Mehti, if you have like a contracted limb like this, what's your approach? Do you use this distraction, with a frame with your ortho colleagues, or how do you graft? I mean, you mentioned skin grafting. How would you manage something like this?
Yeah, we try to involve our orthopedic colleagues in this, and usually it depends on what's contracting the limb. So if it's a bony contracture, then we need to, if it has a bony component, we involve our orthopedic colleagues, but it's usually about having a full release of the soft tissue, the skin itself, any of the the soft tissue, including the tendons, anything that's holding it back. We do a complete release. Skin graft, if there are no non-skin graft accepting structures, like if the paratendon is gone and so on, we tend to go for a flap. But if it's not, if the paratendon is there, if there is enough soft tissue, vascularized soft tissue to accept the graft, then we graft this patient. So it's about having a complete release. So I guess I understand in his case, it's a bony and it's a continual release. That's why he's going for this secondary healing. But what we do is, normally we do a full release and then we graft and then we immobilize, or we put a flap and then immobilize. So immobilization is important for the whole healing process. You can't be continuously moving the limb once you graft and once you flap it.
Yeah, very difficult cases and many different ways to tackle it, but I think this is a great discussion. Sushant, you've had your hand up for a while. Did you want to make a comment? I'm sorry.
I was listening. Yes. So first of all, congratulations to Dr. Saad. Greetings from India. This is a beautiful case. The question which I wanted to ask you was, do you give any medication to your patients, to maintain the blood circulation or the blood flow of the skin which you have you've done a skin grafting to? Do you do anything of that sort, any medication?
I do not know of any medication which can increase the blood flow.
Yeah, no, so it's actually not a medication as such. I work in a Tier 4 city here, so we have something called as tablet Rental, which we give to many of our patients. We don't have a proper plastic surgeon here working, so many of the skin graftings which we do it on our own, the orthopedic surgeons. Yes. So
Yeah.
that is
But
one tablet. Yeah.
what's the name of the tablet? Can you please tell me again?
Tablet rental. I'll look it up properly and I'll send it to you.
Yeah, sure, sure. You know, the distraction histogenesis, the studies claims the blood flow increases to about 400 times
Right.
than it was before. Yeah. So it's,
Yeah. No,
you know,
my
whenever
question,
you
sorry,
do,
was for the sleep
you
tapting.
can actually, this is very evident whenever you're doing a segment transport in tibia, especially.
Right. Right.
And if for some reason, if you have to freshen up the docking site, if you open it up, even the cortical bone is bleeding like a cancellous bone. It's truly amazing. So I actually I've seen it. So the blood flow increases. You see Elizarov even described the technique of patients with ischemic ulcers on the foot and on the distal tibia. He would just do a partial osteotomy of the proximal tibia and would do some very little amount of transport, and the blood flow would increase and the wounds would heal. So the process of distraction histogenesis, it increases the vascularity.
Wow.
So
Great. So
I
thanks
don't
to
believe
this,
that there
we have
can
the
be any
name here.
medicine which can increase the blood flow to an extent like
Yeah.
this process does.
Yeah, no, I guess I missed out on putting it out properly. Thanks to Ellis, we have the name here, the drug name, it's pentoxifylline. That is what the drug is actually, and that we
Okay,
use
okay.
basically for a good skin uptake. I do normally use it for my external fixators, which are comminuted fractures, and I need something going around because not everything we are able to treat by Elizarov over here. So that is the only
Okay,
thing. Thank you for the opportunity.
great.
Thank you, Dr.
Thank you.
Srivastava. It sounds like, Dr. Wickstead, you had your hand up at one point. Do you still have a point to make?
No, that's it. Thank you.
Yeah, I don't want to keep the conference delayed. Just a quick comment and a point. This is an amazing technical feat, but it's also an amazing personal feat. These long, complicated frame cases take a lot out of the patients and their families. It's a little bit of a roller coaster ride because you have a lot of complications with them, and you have to hand carry the patients through all those complications. And just from a standpoint of managing the patients, this is amazing work. This just requires dedication to these people, which is just inspiring, really, because this is a 2-year process, and you're seeing this patient every 2 weeks and carrying them through this journey, and that's really just amazing. Quick question for you: most of your patients that you're showing here are fairly young, and in a 15-year-old, you're going to get tremendous plasticity of the tissues, which is extremely helpful. Can you just comment briefly on how you look at this in terms of age, and when I'm not looking for a number, but just sort of your general take on when you start to do these really amazing corrections, and when you think too much is too much.
Thank you for your nice comments. Actually, me and Dr. Kiran was just discussing it. If the patient has comorbidities like uncontrolled diabetes, or if it's a chronic smoker, so in which I expect that if I'm doing an osteotomy, I want the regen rate is going to be poor. So in those patients, obviously, I'm not going to offer it. But I have done bone transports in patients who are 70 years of age. So if the bone is forming, then obviously the skin will regenerate as well. So as long as the patient is healthy, he doesn't have any comorbidities, I would not take the age factor very seriously. If the patient needs it, I would apply it and I would do it.
Great, thank you.
Thank you, Dr. Aurelius. This has been an excellent talk. There are a couple of quick questions in the chat that require 1-sentence answers. So I'm going to rapid fire ask these questions of you to help give our audience their answers, and then we'll move on to the next case presentations for time. So first, Dr. Sammy was asking about neurogenic pain. Do any of these patients that go through this process develop neurogenic pain, and do you have any preventative strategies for that?
Neurogenic pain, obviously, if you while you're putting a wire and you impale a nerve, then you're going to have a pain. But the distraction phase doesn't generally cause any neurogenic pain. In a patient in which the massive bone loss, if you see the case in detail, I did an osteotomy of the tibia and brought the tibia, proximal part of the tibia and fibula up about 15 centimeters into the thigh, which means, if you think about it, the common peroneal nerve and all these nerves just moved upwards. and he did not have any foot drop, no problem. So the nerves are actually regenerating. So unless you impale a nerve with a pin, neurogenic pain is not a problem.
Next question is, what do you do to avoid pin tract infections?
Obviously, the most important thing is there should be no tent. If you the wire, it's about all about the technique of passing a wire and passing a pin. The wire, if you put a wire, and it should not be, it should be a low revolution drill that passes the wire, and then you have to fix the wire with the ring where it has come out. If you pull it and apply to the frame, so it causes necrosis on the concave side. So it's all about passing your wire, the technique of passing a wire. That's the most important thing.
And
So
Avoid
just-
the pin
so-
track infection.
So just to jump in on that, can you explain that a little bit better on those for people who are unfamiliar with passing these skinny wires?
Yeah. If you pass a wire like this, you see if this is the ring and the wire has come out like this, and if you just pull the wire and fix it with the ring, there will be now a bowstringing of the wire, and now you're tensioning it. The concave side will result in a pressure necrosis of the bone and the tissues. And because of this necrosis, there's going to be a lot of dead tissue for bacteria to grow on. So it's the most important thing is, if the wire has come out like this, you apply a post and fix it where it has come out. So that's the most important thing. And you don't, if you pass a wire, it should cross the medullary canal. It should not just come out from the edge of the cortex. So these are tips which you have to learn while you're passing the wires. This is the most, and then again, obviously you need to keep your fixator clean. You need to do proper dressings. These are all important, but the most important thing is how you're passing your wires and your half pins.
Very good points. And I'm sorry to play the bad guy here, but I have to say that we must move on to the next case. Dr. Ilyas, fantastic presentation and really amazing cases. And thank you to the faculty for a great discussion.
Thank you so much.
Yeah, thank you. If you can bring down your slide, and then I'll invite Dr. Sushant to pull up his slides to present his first case.
Okay.
And to all the faculty, there are a few questions in the chat. If you guys want to chime in and answer some of the participants' questions, please feel free to do so.
Yeah, is my slide visible?
It is.
Okay, thank you. So, a very good evening, warm greetings from the city of Pune. My thanks to Dr. Kiran, the entire team at GOC and Sona for doing this impeccable and wonderful concept of CLET. So diving in straight to my case, this is a grade 3B shaft tibia fracture, which was managed by a WAC dressing and X-fix. And this is a single center experience. So we all know that there's a conversion of provisional external fixation to intramedullary nailing in femur fractures, and it has been reported safe to do it within 14 days of the initial surgery. So normally what we do is we have an X-fix, which we allow the soft tissue to heal, and then we go ahead and put an intramedullary nailing. But there is no current literature which is guiding this practice in tibial fractures. The objective of the study was to compare the uptake of skin graft in treatment of open tibial fractures by external fixation and WAC application, to assess the occurrence of any surgical site infection, soft tissue healing time, time period of conversion from an X-fix to intramedullary nailing, union time and complications like non-union infections and any extra surgical procedure. So we are doing the study at my center, and thanks to sir, I'm showing you one case illustration here. So I still remember this case very well. This had come to us at around 2 o'clock in the night. And I remember going and seeing him in person. And this was a very bad case. I mean, this patient over here, he's a young guy of 28 years of age, came to the AR, absolutely shattered, traveled almost 35 kilometers as a pillion rider with his friend, taking him. And this was the clinical pic. We gave him a very good wash, a good debridement, and took him immediately in the OR. And this is what I could achieve. So now if you see, I've tried to, salvage whatever skin I could. And this is a procedure which my boss had taught me. This is known as a shoelace type of a suturing, in which, like you tie your shoelace, we have two ends coming out. And then every day we tighten the ends, looking at the skin and the edges. We tighten each end every day. So it's like tightening a shoelace. So this is what we call as a shoelace suturing technique. And trust me, it works wonders. Now, when we were dealing with this, we had another wound which was right at the distal end. We had put an X-fix and we had another wound which was at the distal end. This was one thing which was not healing. Okay, I removed the X-fix, everything was fine. I went in, did a intramedullary nailing for him, which was not healing. So what should we do next? We went in, did a whack. Okay, and somehow, we had an infection again. So I had to go in, take out the nail again, and put in a delta fixator. And then this is what was done. Took a skin graft. We put it with the help of staples. I know the plastic surgeons would jump on me, but please bear with me. I'm a trauma surgeon and trying to do whatever best I learned in my residency, thanks to my plastic surgeon colleagues. And this is the final pic which I have down there. So in conclusion, whatever study we did, it allowed us to reach, a proper consensus in management of open tibial fractures. But there was a caveat in this. Whatever soft tissues we are not able to heal with proper soft tissue healing, we go in, we put a whack, and it gives us amazing results. With increasing vehicular accidents and open fractures, we believe this can be replicated in all other fractures as well. And we can have a proper study, a multicentric trial, where we have a proper consensus as to how quickly we can move from an X-fix to an intramedullary device, and how quickly each and every soft tissue healing would differ from the upper limb, the lower limb, and different parts of the body. So this is what I did again, is I removed the delta fixator, put in a nail, and he's doing fine now. These are my references. Thank you very much. This is my unit.
Thanks, Sushant. Do you mind going back to the slide where you show the shoelace technique?
Yes.
So this is pretty great. You talked about a lot of different aspects of the reconstructive ladder in this case. We talked about primary closure. We talked about using a wound vac and hoping to heal by secondary intention. You talked about using a skin graft. I wonder, when you place a wound vac, many people go back and they change the vac at a certain frequency. Can you talk a little bit about how you manage the wound vac, and perhaps other panelists can talk about how often they take the patient back when somebody has negative pressure wound therapy in place?
Yeah, thank you for your question, Alice. So what we do is we check for the amount of discharge which is being collected in the vac machine. So we have a proper charting of the amount of the discharge which is getting collected, and anytime we feel sometimes, which we normally notice is the basic thing which we do is, if it's for a femur fracture, we take at least 3 to 4 days, and when it comes to tibia, especially such superficial wounds, we go in and we change it in 3 days.
I see that Dr. Woolley has his hands up. Would you like to make a comment, Dr. Woolley?
Yeah, that's a great case. I like the shoe lace technique. I'm just wondering, in the reconstruction ladder, if you thought about just doing separate incisions on both sides, just kind of release the tension of the skin and then close it off. Or did you feel like that was sufficient to every single day kind of tighten up? Because it feels like some of those areas could get risk of necrotic tissue, especially on the most proximal part, where your first pen is. It's a great way to close it off, but maybe just, in my opinion, like 2 separate incisions on each side, kind of soft tissue, and just kind of close it off would be also an option that I would be thinking of while doing this. I'm not a plastic surgeon at all, so I'm just giving my orthopedic reconstruction ideas.
Yeah, thank you for your question, Willie. So a very valid point. I had these questions too when I saw my boss doing this. But one thing which I've realized is this is something which we do, in a transitional way. It's not that we do it every day. We allow the wound to heal for some time. It's done every 2 or 3 days. So it gives them enough amount of time and space for the swelling to decrease. I know it's a very angry looking wound right now, but trust me, I have a slide which just goes next to this. Look at this. So this is what we've been able to achieve in like 10-15 days. And this is without VAC. And if you just go down over here, this was normal suturing and this did not heal up on the medial side. And that is where we had to do VAC. So, I mean, this has helped us. I have not been able to, publish this as of now. And I'm looking forward to doing this very soon. And this is one of those Indian jugars we, pride ourselves to. So, yeah, thank you.
Dr. Srivastava, then one of the questions in the chat, I think somebody was really curious about the shoelace technique. Can you walk us step by step through your shoelace technique?
Yes. So so what you should do is you consider your wound, okay, to be the outer perimeter of how you're putting your feet inside the shoe, and consider each part there as those small openings which you have to put in your lace. So what we do is you go the way our dad and my mom has taught. You go on one side, take a suture, go on the other side, transfer, then go on the other side. So what is going to happen is always keep good amount of ethanol at the end of one end. And because when you have to go there and transfer, you need to come back and tie it on the other side. Okay. And every day, what you're going to do is, as and when the swelling decreases, you are going to pull it. You're going to stretch it and you're going to pull it, and you're going to see an approximation which is going to happen from the distal end. Okay. And as and when you keep on coming down and down, you'll see the ends coming closer to each other, and you would be achieving. Yeah, I know this sounds very lancet. It is there to see. You need to see to believe. And I'll be very honest.
Thanks, Vishant. We have hands raised from two of our plastic surgery colleagues here at Harvard, and I'd love to hear their opinions about.
I should be scared.
No, please don't. All in the spirit of collegiality. Sammy, you had your hand first, and then Lydia, you next, please. Sammy, go ahead.
Yeah, I think, thank you. I use this technique. So I think this is totally valid. I think it's smart. We call it here Jacob's ladder, but there are also now commercial devices that, companies sell to do the same thing. But this is like a really cost-effective, straightforward way, safe way to do it. I think it's great. It works very well. I usually use Proline because it tends to glide better, and I get less. I find it's less reactive. The sutures. I think the smart part about this is not closing it, like not forcing it closed, because then everything will necrose. That whole wound margin will necrose, and you can't do this. Then you're committed to doing something more sophisticated. And then my question to you is that skin graft over the ankle, it looked like this over this wound here. Was this over the fracture, directly over the fracture?
Yeah, so I what I gather from this case was it was it was a very bad wound which was not healing, and there was a lot of oozing which was happening. It was not actually on the fracture side, but it was a very bad wound which was not healing.
Understood. Okay, thank you.
Thank you.
I think the important point here is it's actually kind of like Dr. Ilyas's lecture on distraction histiogenesis, isn't it? Slowly stretching the skin over time. So Lydia, did you have a comment to make?
I was actually going to say something similar to Sammy, but I'll also weigh in about the VAC. If you think about the way the VAC works and the way Jacob's ladder works, it's sort of a similar idea, especially if you cut the sponge to be a little bit smaller than the wound. It's going to be pulling the edges of the wound in. So it's actually acting in a very similar fashion. So I think we obviously love the VAC. We change it in my practice usually every 3 to 4 days, depending on what the wound is like. It's less about what the drainage is and more about preventing this sort of like wet sponge from sitting in a wound that could potentially be infected. I'm curious, Dr. Sushant, what you have found in terms of your rates of healing of the bone underneath, because one of the things that we always worry about when we VAC an open fracture or allow an open fracture to heal by secondary intention is that ultimately the bone is infected underneath and it never heals. So I'd be curious to hear about your success rate with that.
Yeah, so thank you for the question, Ilya. What I have noticed in my short experience is that with a proper stabilization, with a proper X-fix, the wound healing is just fine. I mean, I have not encountered any case in which there has been a non-union, or I have had a case. This was one case wherein everything happened with this patient. It got infected, and then I had to go in, remove the nail again, put a delta fixator, go and do a skin grafting for this non-healing wound, and then put in a nail again. This was one case in my experience where I had everything thrown at me.
So it does sound, Dr. Srivastava, a lot of people are interested in this Jacob's ladder / shoelace technique. Perhaps we can put together a little technique video to send everyone afterward as a collaboration with Dr. Sammy, Dr. Helliwell, Dr. Srivastava. I noticed that both Dr. Wickstead and Dr. Ilias have their hands up. Dr. Wickstead, do you have a quick comment?
I do. Just a couple of quick comments. Number one, beautiful case. It's nice to see, the sort of commitment to really salvaging people. This takes a lot of time and effort. So beautiful case. Be careful of compartment syndrome. As much as this technique of the Jacob's ladder is a great way to gradually stretch the skin over things, for acute open tibia fractures, compartment syndrome is a real risk, and you shouldn't try this kind of a technique, right away, or compromise, potential fasciotomies that patients may need for limb salvage. And the second comment I would make is that I think this is a nice technique when you have a frame in place. I suspect it's going to be a lot less successful if you had a nail in place or a higher burden of metal inside the leg. So I think your strategy here of put the frame on, get the skin stretched, get things closed, and then nail them once you've got better control over the soft tissues is likely to be far more successful. If you nail these immediately and then try and do this technique, I think you're going to be very unhappy with the infections.
Yeah, absolutely correct. So you
Really
just hit it.
important.
Yeah,
Very
absolutely right.
important. So I'm sorry to again play the timekeeper here. Dr. Ilias, you have your hand up. I'll have you please just make a 30-second comment as we transition to the next case, please.
So just one question I had. Have you ever had a complaint of skin, the suture cutting through into the skin? Because the area of the skin is inflamed, while you're pulling the skin, that edges break, and
Nothing.
you never had
Never.
Oh, okay. I just wanted to inquire. Thank you so much.
I have had that problem in patients with very friable skin, but that's mainly because my patient population is more geriatric than I think Sushant's patient population.
So with this, it's easier if you pass. I have a 1 millimeter K wire, and you just put it like this. Bring it in, bring it back when the margins, and then loop your thread through that K wire. Then the tension of the wire it's like homogeneous, and it doesn't break that way. So I use it this way. I always put a 1 millimeter K wire with my hand like this, bring it out, bring it in, like seesaw, and then loop it with the wire. So that's how you don't get any cutting or breaking of the skin.
You showed that with your calcaneus technique. That's very interesting.
Yeah, exactly.
Fasi, do you want to bring up your slides? Let's move on to the next presentation. I think this one will also have very similar points to discuss. We're sort of moving up the ladder, the reconstructive ladder here. So,
can you see my slides?
yes.
Okay. Thank you. Welcome, everyone. I would really like to thank Kiran and his team who have put up a very good show. This is 4th week in a row for me as well with them. So this case presentation is about an open tibia fracture in which we did a staged approach. So this case is a 30-year-old male truck driver who he was doing some repair work with his tires, and his brake failed, and the tire of a truck went over his leg, and he had a crush leg under the tire. So the X-ray is shown in the picture, but the main problem with this X-ray was his soft tissue. So when he presented to us, he presented with this picture. The first hospital that he went to, they advised him amputation straight away. obviously they didn't want to go in patient, so they went for a different place. So this is when he came to us directly at night. So at the time when he presented, he was in a state of shock. And what we did in the emergency room was a bit saline irrigation, saline wash, and we tried to close the skin, the degloved skin. We tried to put it back and put in with 2 sutures. And then the patient was taken over by the medical team because he had very high levels of creatinine. He had his HP was very low, and he was a bit unconscious. So they kind of stabilized the patient first. So after resuscitation, when we took him back to the operating room, this was his condition at the time. The skin that we kind of approximated together had necrosed, and then he had a fracture. So what we did is something that we do quite commonly here is even in open fractures, we do intramedullary nail. So because if you have a solid bed or solid bone, so then you get to the chances of infection are less considering your soft tissues. So after this, what we did, we closed the deep fascia, and we tried to close as much skin as possible. Important point here, the 2 important point here are that once you have to you have to go according to the structures, the deep layers. So if you can get a good closure of deep fascia, because deep fascia is a hard tissue, and the muscles and the fibril tissue, you're not going to get enough tension on them. So if you have do your proper dissection, and if you have deep fascia, then if you close it, then you can have a pretty good closure with this. Once you get the deep fascia closed, then there's always temptation that you can primarily close the skin, but this is temptation you have to resist. You have to keep it a bit open, so to minimize the tension on it. We do use vancomycin powder for such open cases. So this was after the surgery, what we did. So we tried to close in as much as possible, but we did not fully closed it. We know the skin on the posteromedial skin was not that great. So we did expected it to necrose over time, but we just wanted to save as much skin as possible. So this is when he presented after 2 weeks. So this picture was taken after the gangrenous skin was cut. And at this point in time, we went ahead and we did skin grafting. Those of you who are familiar with sign technique, they have a skin measure, which kind of gives a pretty good meshed skin. So we went ahead and we did a skin graft, and we put in the skin and skin graft. And as you can see, at follow-up after a week and after almost 3 weeks, the skin was healing pretty well. This was his soft tissue at around 7 weeks time. And this was his final picture at about 4 months time. So he's able to fully walk. He has slight discharge where the leg screw is. Otherwise, he's fully mobile. He's able to weight bear, and the skin has healed pretty well. So just a thought about this case being that what could have been done better with this? Maybe if we could have access to a negative pressure wound therapy or a VAC, then we could have applied it in the first place, and we could have gotten away with a bit less skin necrosis, and we could have been, the skin grafting would have been a bit less than what we did. So with this, we would go with for the discussions part. Thank you for your patient listening.
Thanks, Basi. Excellent case. Just a question. You're saying that the patient is still discharging from the wound now after, do you think the nail is infected?
No, when he presented at the last follow-up, he had some discharge from when he presented at 51 days, he had slight discharge from that leg screw site, but with the 1 week antibiotic course that settled down.
And there's a question in the chat about reamed versus unreamed. Can you explain a little bit more about your selection of why nailing these cases? And like, I just worry about potentially, as Dr. Wickstead said in the previous case, like potentially risking infection.
Yeah, so infection is a common pitfall in these cases. But the thing is, if you can get a good solid reduction, if your fixation is good, then the chances of infection kind of decreases. So if the more instability there is, the more chances of infection there is. If you can get a good reduction, if you can get stable fixation, then the chances of infection do go down. But having said this, reamed or unreamed nail, because the sign nail is a solid nail, so it's basically we have to ream it, and then we do use ream nailing, and most of these cases of tibia we do under tourniquet as well.
Interesting. Yeah, thank you for this. Any comments from our plastic surgery colleagues on the approach, like perhaps different techniques that may have been useful for closing this? Fasi, it seems like you were able to rearrange some of the deep tissues to cover the bone. Is that right? In order to create a
Yeah.
surface for the skin graft?
Yes. So because the deep tissue is tough. So if you can get sutures in the deep tissue, you're able to get it closed pretty well, because the muscles are pretty friable. Even the skin is pretty friable as well. So deep tissue is a tough tissue. So if you get a hold of that, then you'll be able to close it well.
Lydia, did you have a comment on how would you have approached this as a plastic?
This is a really hard case, as I think it's obvious to all of us. Any wound in the distal third with exposed bone, there's essentially no extra skin. So I think the fact that you were able to get this closed is actually pretty impressive. I'm surprised you were able to, which is great. I do worry when you allow for a lot of secondary healing over open fracture, that eventually it does get, infection is a big problem. So it'll be interesting to see if that bone heals. In our center, we would probably do free tissue transfer for this. Just because pedicled flaps in a really traumatized, like his mid third is really traumatized. So something like a propeller flap or even a reverse soleus flap, like any of those things are going to be really difficult because of how traumatized that leg already is. So I think if free tissue is not available, which would be my first choice for this, I think what you did is great. And I think you have eventually gotten him closed. You may end up finding that bone is infected and you have to do some extra to get it eventually healed. But the fact that you're able to now have pretty stable soft tissue coverage, I think means that you'll be able to do that potentially if you run into that problem.
It's sort of this approach that Fasi took kind of reminds me of the flap and fix method that we typically use in high resource settings, right? Where we're debriding and then we nail the tibia and then do a flap, usually a free flap. In this case, sort of like nailing the tibia and then trying to get the skin graft because the free flap obviously wasn't available. Yeah, I mean, very.
And I think the risk is that you run into infection. Like our goal of fixing and flapping is to try and prevent infection and long-term wound difficulties and non-union of the bone, which is obviously maybe the most important thing. So if you can do that in an ideal setting, great. But ultimately you have gotten pretty good soft tissue closure down here. And if you need to address the infection underneath, you may be able to take the hardware out, debride, etc. It just prolongs the whole course. But I do think a vac would have helped for sure, made things faster, smaller, less graft. And yeah, in high resource setting, this fix and flap, I think the rates of infection are definitely lower as a result.
I'd like to.
Yeah, I totally agree with this. The thing being that it being a distal third tibia fracture as well, which are kind of prone to slow healing compared to, like, say, proximal or middle third of the tibia. At 4 months down the line, he's able to walk without any support. So I think, and the X-ray does show a bit signs of healing. So I think he's going in the right way. But yeah, the point of these cases being very high risk of infection, that's a very big issue in this. But again, if you have a stable implant, stable fixation, so if you can make the fracture heal, even with infection, that's a good sign. And if it's infected, you can take the hardware out, and the infection will settle with it as well.
So Dr. Helliwell and everyone on the panel, as a junior resident, I think one quick concept that would be helpful for all of us to clarify that's been brought up by this case is, when do you graft and when do you flap with open fractures? And perhaps you could quickly answer that question before we move on to Dr. Abebe.
Yeah, I think skin graft, you need good healthy tissue at the bottom. So most of the skin graft has taken over healthy muscle. You can do it over tendon and bone if there's good periosteum potentially and good peritoneum, but it's very risky and often doesn't take. So you're thinking flap as in either free tissue transfer or pedicle flap, either muscle or fascia cutaneous, when you have exposed bone that is fractured. Sometimes you can get secondary healing over bone that's not fractured, but when there's a fracture involved, we're really thinking flap because the skin graft won't take on bone directly.
Great, thank you so much. Meti, Dr. Abebe, did you have something to say?
I think most of it was mentioned by Dr. Helwell, but just wanted to say like our first line of management in the resource limited setting is not a free flap for most of us. So I think he did quite well, and he was just asking about VAC. So the VAC would have made the skin graft smaller and maybe did not shorten the duration of my final healing in this case, but I think what was done was quite appropriate with the setup he had, because I don't think the rest of the tissue that he thought he debrided could have been salvaged by anyway, because it was already degloved and it had no blood supply to it. So I think the ages were debrided correctly, and this is as good as it gets. But if the option of VAC is there, the area of grafting would have been smaller. That's all, and then the shorter duration would have taken for the maximal healing.
Dr. Shahab, there's an interesting question in the chat, which is for open fracture management, should you only internally fix the fracture if you have a stable soft tissue cover? Perhaps you can talk about the timing of soft tissue coverage versus fixation of the fracture.
It's just one of the hot topics in trauma. So our approach over the years has been that we do, even for open fractures of the tibia, femur, we do tend to do interlocking nail with this. We have a series which is almost there to be published on intermittent nailing of open fractures. And we did see, if it's not 3B, anything less than 3B, you do get very good results. Because the main issue here are two. One is the chance of infection, and also delayed healing, because the higher the tissue, the injury is to the bone, the more the periosteum is stripped off, the more the muscle damage and the vascular damage. So the bone is a bit slow to heal. But we, in our study, which was basically a sign database study in which we looked at over about 5,000 to 8,000 cases, and we did see that we had very good results over there. So again, the main concept being stability. If you have a good stability, then the chances of infection are low.
Great, thank you. I think for time, we'll end with this comment from Dr. Wickstead and then move on to the next case.
That's a great case. I'll just make a couple of brief comments. I think this is successful because you have a relatively simple fracture and the nail stabilized it nicely. I think for a more comminuted fracture, you're going to have more difficulty. We tend to think of the circular frames as, either you get a nail or you're in a circular frame for a year, which isn't really the case. You can use a circular frame to provide the stability you need to get the soft tissue stabilized. So in a more comminuted fracture, you can use a series of lag screws, maybe a little small plate, keep the metal burden low, and a circular frame on top of it to bridge you to the point where you can get a nail in there, right? So tibia loves a nail, but you need 6 or 8 weeks to get the soft tissues under control. And a nice way to do that is to use, lag screws, limited internal fixation, and a spanning frame while you're dealing with the soft tissues, with the full intention of coming back and putting a nail in once you're stabilized. And the last point I would make is that acute shortening is a great way to facilitate this kind of treatment if you don't have access to a flap. So for those of you who don't have a micro person standing by or a big microscope to do an ALT flap, and are going to be faced with situations like this where you're going to do acute closures, shortening the fracture can turn your defect from one which requires a flap into one that can be treated locally. So you can always make the thing longer at the other end of the bone, well away from the fracture site. But if you've got a distal third tibia that's quite comminuted, acutely shorten that thing. You can acutely shorten them 5, 6, 7 centimeters without really any difficulty, and lengthen it back at the other end. So just, a pitch for acute shortening as a way to simplify your soft tissue closure, then come back at 8, 10 weeks when you've got your soft tissue under control and put your nail in at that point. Thank you.
Thanks, Jack. Great point. And we actually have your lecture as part of the core curriculum online, free for everybody who's interested in checking out your technique on acute shortening. Fassi, so you had your hand up for a moment. I don't know if you want to make a quick comment before we move to Kawemi's, but we're about 10 minutes behind schedule. So maybe just...
I totally agree with the comments, and he has a wonderful lecture as well in the core curriculum. I just agree with the point. Ideally, it should be stage, X-fix first, put in limited fixation, then come back. But the problem here in limited resource setting is that being an X-fix surgery or being a nail surgery, the patient has to pay the cost for both of them. So it's kind of difficult for them for paying for both. Ideally, that's the way. But in terms of limited resource settings, we have to have like one shot. So we try to do our best, and so give the patients the benefit of it.
That's such an important point, Fassi. Thank you for that. Well, for the purposes of time, let's transition now to Dr. Kawemi Mwafulirwa's lecture. Kawemi, please, the floor is yours. Kawemi, we can't hear you.
All right, how's that? Can you hear me now?
Yes, we can. And we can see your slides as well.
All right. Kawemi Mwafulirwa. I'm an orthopedic trauma surgeon from Malawi, Queen Elizabeth. I thought I'd share a case that we recently, a 15-year-old boy who had a disseminated Staph aureus infection. As a result of that disseminated Staph aureus infection, they had left tibial osteomyelitis and right hand abscess. They were taken to theater after appropriate bloods were taken. They had debridement and a cortical window and bone drilling to let out the pus that was in the tibia. Post-op, we were left with soft tissue problems. They had a left leg pus discharged, exposed bone with no periosteal covering. You can see on the sort of medial aspect of the tibia, proximally and the middle 1/3, he has these very large wounds and the bone is exposed. You can see his x-rays done soon after the corticotomy and the bone drilling. You can see where the corticotomy was done in the tibia. No obvious signs of chronic osteomyelitis. Of note is the child was malnourished. The immediate FBC post-op, their white cell count was 20.7. It was elevated. They had a low HP and a low platelet. We transfused them 3 outlet and 1 PEDS unit blood. Post-transfusion, their HP came up to about 8.2. They still had an elevated white cell count of 11.8 and fairly normal platelets. On day 7, following the debridement, you can see there's still a bit of pus discharge. You see obviously exposed bone with no periosteal covering. You can see the bone is dying and there's no blood supply. So our plan at this point, we discussed with the guardians issues at hand, which were poor soft tissue envelope, ongoing infection. Our plan was for debridement and rotational muscle flap. Obviously, when you have an infection this severe and you have soft tissue issues like this, you have to, from the get-go, start to discuss with the guardian that you might not be able to salvage the limb. So this discussion was had with the guardian. You will have noticed, even just by looking at this patient's leg, it looks very small. I think it's even smaller than my forearm. They were malnourished, so we started them on a high protein diet, realizing that if you're managing soft tissue issues, you want healing, you need to manage patient's nutrition as well. We continued antibiotics. At this point, we were giving the child broad spectrum IV antibiotics. We had no culture results as of yet. and continue analgesia. Physiotherapy, both for the hand and the lower leg, was continued. This is often a fact we forget, to continue rehabilitating these patients while they're undergoing treatment. So we decided to take them into theater. Of course, the HB was low, so we transfused them 1 extra unit to at least bring them up to somewhere near 10. As you're aware, blood is an issue in our resource-limited settings. We saved 1 unit for theater, bearing in mind that they would lose some blood. So we went in again to do a debridement, an aggressive debridement, decided to do a corticotomy of the exposed and dead necrotic. So you can see the post-op X-ray. It was quite a large, 1/3 of the bone. Did washout. As you're aware, dilution is the solution to pollution. And went ahead to do rotational flaps, medial gastroc and a hemisoleus. Of course, preoperatively, one of our concerns was looking at the child malnourished, the age. Concerns was that their muscles would not be developed enough. Would find very small muscles that could barely cover the bone. But thankfully, we were able to cover the defect and cover the bone. We made some incisions through the aponeurosis to sort of get a bit more width from our flaps so that we could completely cover the exposed bone. Took a sample for microscopy and sensitivity and continued them on broad spectrum antibiotic cover meanwhile. Day 4 left the wound unexposed until day 4. Day 4 was the first wound inspection. It looked good.
His job at the White House for this.
The muscle was still viable. We continued to dress with betadine, Vaseline gauze post-operatively. You can see no longer having any pus. There is still a bit of discharge, but not too much. Obviously of concern, as we kept on dressing the wound, by day 7, we had noticed that a bit of the aponeurosis had developed necrosis. You can see distally right over there. We monitored it for the time being, continued to dress with betadine and Vaseline gauze dressings. By day 11, the wound was still doing well. You can see there's no pus discharge, not much discharging. The infection is starting to settle. We continued our high protein diet, still had the necrotic patch of the aponeurosis. At this point, we considered theater for debridement, just to debride this necrotic patch, being very well aware that these could be sites, noduses of infection for the child. In the meantime, while we're waiting for theater, take the child to theater, continued use of dressings. Our microscopy, culture, and sensitivity came back with no growth, and so we continued broad spectrum antibiotics. By day 19, you can see we never managed to take the child to theater, unfortunately, because of theater was extremely overwhelmed. But by day 19, you can see the wound is doing very well. There are no signs of infection. There's no pus. The flap has taken very well. It's granuating well. The infection has cleared. At this point, our plan was for an SSG. Unfortunately, kind of reminds us that when you're trying to do any reconstructive work, always make sure as the surgeon, you're prepared for the case and the patient is also prepared for the case. Unfortunately, at this point, the patient decided that they were doing well and their wound was healing well, and they elected not to have a split skin graft. They were quite comfortable to let it heal just by secondary intention. Thank you.
Thanks, Koemi. Can you go back to the slide where you showed the first post-operative image of the flaps that you performed?
Yeah.
Actually, the slide next to that, Dr. Mafulira.
This one?
Yeah, that's
excellent. So, Dr. Mafulira, thank you very much for this talk. One thing that comes up for me for this, especially in the setting of infection is that debridement, good debridement is incredibly important to help ensure the healing of these tissues and help make sure that an infection like this doesn't recur. How do you decide how far to debride to?
Well, in terms of the bone, I tend to use, if it's not vascularized, if it doesn't have periosteum, it needs to go. I check for the paprika site. Some of you might be aware of that. You drill into the bone and try to see if you have any punctuate bleeding. And that sort of tells you that the bone is well vascularized. Dead bone has to go. It's a nidus for infection. If it doesn't have soft tissue coverage, it's just going to bring on infection. In terms of the muscles, it's the same. Sees the consistency, the color, the contractility. And with the skin as well, sometimes we tend to be a little bit too generous. If it looks suspicious, you're better off erring on the side of caution and debriding it up.
Thank you. And I wonder if Dr. Blair could comment on this. I know that there are some surgeons who actually recommend calling it a debridement and irrigation because they want to highlight how important the debridement part is. And I think you're part of that camp. Is that correct, Dr. Blair?
Yes, I am, and I guess as my disclosure, I'm an orthopedic trauma surgeon. I have no formal microvascular experience, and I do cases similar to this. And so, first, to commend you, this is an outstanding result for a very complex problem. And I think, or what the big question that I had is, what are your strategies in these situations for getting intramedullary infection control? I mean, I see that you have exposed cortex, and I understand debriding that, but is there a concern that there's intramedullary infection as well, or intramedullary osteomyelitis?
Yes, I always have that concern. So once we did our corticotomy, we're sure to cure it intramedullary, do a vigorous washout. Dilution is the solution to pollution. So I tend to do quite a lot of washout with normal saline. When hydrogen peroxide is available, I sometimes add it to my solution as well. But definitely curating inside the intramedullary canal and washing that out as well.
I think these are very elegant solutions. Congratulations for these.
I wanted to bring Dr. Mehdi Habibeh and talk about the extremes of what you can do without a free flap, considering the large defect, soft tissue defect that this patient had. Maybe you can talk about some of your experience with your burn patients.
Yeah, sure. Kwame, great case. Yeah, this is, I think, very much handled as much as it can be handled with the resource limitations. Yeah, he has used the gastroc as well as the soleus muscle. There's a good soft tissue coverage, and the wound looks so good. It's ready to be covered, but I guess if the patients are not on board with us, we can't really do much. But this pedicled muscle flaps and so on are good options. What worries me here would be, like, it's a hemisoleus actually, and if there's no problem with the mobility, it should be fine. But it's a good option. He had a proximal third, a middle third defect, and it was an appropriate one, and I think he did quite well. If they could just agree for a skin graft, this would have been done for them, but I guess it's up to the patient's decision. Yeah.
Dr. Did you have a comment?
I just had a quick question for Koemi. How did you manage the wound after the flaps? Did you just do soft dressings, like gauze dressings, Dakin solution? What did you use?
We just use soft dressings, mainly betadine and Vaseline gauze. I mean, at some point we had considered putting a vac dressing to sort of optimize the wound for skin grafting. But, you know, after it started to do so well, we realized that we could get away without using a vac. But definitely a vac was something we also considered as part of our therapy.
And great question from Jack, just really quickly before we go to Sammy. Did you were mentioning you kept the patient on antibiotics, I think systemic broad spectrum, right?
Yeah.
To manage
yeah.
yeah. And how did you transition to orals, or did you, like, when did you stop giving the antibiotics?
So in the acute phase, we kept on giving IV. So this was mainly in the immediately pre-op and post-op, we kept on giving IV. But once we saw that, which was by about the second week, we had controlled the infection, we switched to oral antibiotics. So they were given a standard 6-week dose of antibiotics.
And James brought up a very interesting point about perhaps doing the skin graft at the same time, like at the same time as the rotational muscle flap. Was that considered, or was it always planned to be staged?
I mean, in the setting of trauma, I would consider that. What you're dealing with is an open fracture. You've gotten a very good debridement. You did your washout, and you're sure this is not a wound that's continuing to evolve. Yeah, I would skin graft in the same setting. I think it's easier on the patient. In this setting where I was dealing with an active infection, wasn't so confident a skin graft would take in that setting, so I decided to stage it.
I think that's reasonable. Sammy, please go ahead.
Well, yeah, this is obviously a reconstructive success. I had a couple of the similar questions. I think this picture shows clearly the hemisoleus doesn't have the same robust kind of appearance as the gastroc, and that's what I see as well. I mean, if I ever use a soleus, a hemisoleus, I try not to because of this issue. You got away with it, and I have also gotten away with it at times, but not always. And my flaps look just the same. Like the soleus has this kind of grayish more appearance, and eventually it perked up in this case. So that was good. I think the one thing I have had issues with is desiccation. So like when that aponeurosis of the soleus, even the gastroc, if you do flip it the other way around and have to use it the other way around, that can desiccate if you don't graft it right away. So if I don't graft it, I'll vac it. And I'll put something like, Vaseline impregnated gauze or something on it to keep it moist. The other option, if you don't have vac accessible, one of my mentors taught me these wet downs. So you can just basically every day go in and just keep soaking the wound a bunch of times a day, just so it doesn't desiccate. Because once that marginally viable tissue desiccates, you're done. So then it just dies. So just a couple of comments, but I think this is clearly a success. Amazing.
Last comment from Lydia on this case before we transition to the final case presentation, just for the purpose of the time. Thank you all for staying a little longer for today because these are excellent cases. Lydia, please go ahead.
I'll be quick. I think the hemisoleus, I think it was actually a good use in this case because it wasn't a trauma case. Trauma cases where the tibia is fractured, your soleus is obviously a lot closer to the bone and a lot more likely to be injured as part of the overall trauma. So that's just one thing to consider because this was an infection and something sort of separate. I think the hemisoleus actually is a good solution for this, and it was great. I think staging it was totally reasonable, so you don't waste a graft if you're worried there's still a little bit of infection going on. And then I just want to say, for those that don't have plastic surgeons around, a hemisoleus is trickier, but a gastroc is actually relatively straightforward. There's not a lot you can injure. The pedicle is really high in the popliteal fossa, so if you learn how to do this, it can definitely help you with a lot of proximal third defects, knee defects. And it's actually relatively straightforward to do. Hemisoleus is a little trickier, but again, if you know your anatomy and and you're doing it in a non-traumatic wound, and there's good anatomy, it also can be fairly easily done. So great solution for this. Nice job.
Excellent, Komi. Thank you very much. If I could invite our last speaker, Dr. Arseni Friend, to present his case. And thank you all. I know that we're a little bit behind schedule here, but I think we'll all very much gain a lot from this last case by Arsène from Haiti.
Thank you, Dr. Kiran, for the introduction. Let me first thank Harvard Global Orthopedic Collaborative and Sona Global for their effort to improve orthopedic care around the world. And at this special time, I want to ask you to think about the Asian people who are experiences a tragedy where even the biggest hospital in this country was destroyed. We hope that the spirit of our ancestors will guide us to resist and emerge from chaos. Let's go to the case presentation. We have, excuse me. Okay. Excuse me. Like objective, we want to share our experiences in the management of complex soft tissue losses in the lower extremity, and we want to motivate young orthopedic surgeon, particularly those that work in condition with limited resources. Our case is a patient with 7-year-old male with pain and functional limitation in large bone exposure of the anterior external region of the right leg after a domestic accident where a wall fell on his right leg. No underlying comorbidities, distal pulse not felt, but oxygen saturation in the toes were at 84%. After pediatric evaluation and the lab tests, we decided to go to the surgery room to try to help this patient. Before our surgery, I share with you the X-ray of my patient. And when we go to the surgical room, first we did a large debridement and we placed an external fixator and a vac. Unfortunately, after 4 days, the vac machine had an issue, so we have to remove the vac. This was the case. So after 5 days from the first surgery and with the issue with the vac system, so after that we have to go back to the operating room and perform a flap. We decided on this case to do a cross-leg flap. To do the cross-leg flap, we go to the donor site after under, so below the fibula, and we try to do our incision depend on the donor side and the side that will receive the flap or in our wound. And we try to keep on this case the fascia. So we take the skin, we take the subcutaneous tissue and the fascia. So after that, we put it on the wound after another large debridement, and then we did the suture. This is another view after the flap surgery. This was after 5 days from the second surgery, the first dressing change. And after 22 days post cross-leg, it was our patient. And at the same time, we decided to do the separation and to remove the external fixation. But we had also a bone loss, and we have no semen available and no circular frame available. So then we decided to put a signal, a pediatric signal after a PCR, a negative PCR. So this is another picture. Here we separate the legs and we remove the external fixator and we place the signal, the pediatric signal. We also put bone graft. Bone graft we take from the fibula and the metaphysis, like at the same place when we drill to lock the nail. This was the first X-ray after kneeling, 1 day after kneeling, and after 5 months, it was the result. 5 months post flap. This is the flap. Okay, so this is a video of our patient after 5 months post surgery. Okay. Thank you so very much. I'm waiting for your comments and question. Thank you.
Remarkable limb salvage, Arsene. Fantastic. Can you go back to the slide where you showed the first image of the cross-leg flap that you performed? Just a quick question for you. How did you manage the donor site wound? Did you skin graft that? This wound right here on the back of the donor site?
Okay. On this case, after the surgery, the parents didn't want to do the skin graft at the same time. So first, after explaining to them what we're gonna do, they asked us no problem, they can leave this for self healing or a secondary granulation, but they didn't want to do another surgery at the same place to cover this part. So that's why we didn't do it. But naturally, we can do a skin graft to protect the donor site.
Thanks, Arsene. Any comments from the faculty on this case? Those with experience. Mehdi, I'm not sure if you've ever done cross-leg flap, but we have a comment from Pierre-Marie. Why don't we start with Pierre-Marie?
Yeah, this is a fantastic, great case and great case. Ethan, I very happy and proud of you for what you're doing. Yeah, I've done
Thank you.
quite a few of these cases, and some kind of typical point. First of all, is these are your extreme cases where you do not have any options, and you really need to do something. So this is like on top of the ladder, right? This is not something that we would want people to do as an initial manager unless they're really in a very tight spot. But by doing them, one thing that I found useful is being able to utilize the external fixator to not have because the patient is going to be, stuck, the two legs going to be stuck together anyway for about 21 days. And then so when we use the external fixator, we use like a bar in the bottom so that their legs are actually elevated. It actually helps not only with elevation and revascularization, but also just not pressure of the leg on the beds or stuff like that. So those are simple things to do. But I think that if it fails, the cross-leg flap that's been described for, I don't know, generations, is definitely an option, and I really commend Ethan for that case. Absolutely.
Can I maybe
Thank
ask?
you.
Yeah, thanks. Can I ask maybe a bit of a silly question? How does a patient use the toilet? You know, is that an where the legs are stuck together like this?
I'll let you can answer, but it's hard. It's really a horrible 21 days for everybody. I'll tell you that. It's like a patient with a spica that you're gonna put. It's just really hard.
I think maybe that's an important teaching point with this, is that this is not easy for the patient, obviously, to have their legs stuck together like this. Mehdi, I know that you don't often have access to free flap facilities in your hospital, and I've seen you do incredible cases with pedicle flaps to manage defects all over the body. Curious what you think of this.
Yeah,
Thank you.
it's a very useful flap. Congratulations, Dr. Arsen, on this. Like, it's when you are at the last resort where you can't really do any local flaps or any pedicle flaps, cross-leg flap is an option, especially for pediatric patients, where you're able to move them around, as you said, even to use the toilet and so on. They need the parents, and and when I feel like the cross-leg flap is very forgiving in the pediatric age group because they're very flexible. They tend to manage quite well. We have done it in a couple of adult patients as well. It doesn't go as well as in the pediatric patients, but it's it's in the armamentarium of management in the resource limited setup, and we have used it before. And in pediatrics, they have the parts. It's a 3-week thing, and then it works quite well.
Thank you.
Yeah, thanks. Question, I think, from James. James, did you want to ask your question live?
Yes, absolutely. I appreciate that. Amazing case, and this is an outstanding execution of this. But my question is, for those of us who are not as familiar with this, how do you know when the donor pedicle can be cut, and that the recipient flap will survive and the external fixator can be removed? Is it just a matter of time, or is there something specific that you're looking for?
First, we have a protocol. From our protocol, depend on the evolution, depend on the healing when we are doing the dressing. Okay, after 22 days, we have to do the separation. We have to cut the flap, but we have to base on the evolution, on the cicatrization, on the healing. So that's why we have to take both part, respect the time, and be care about the evolution of the wound. Yeah.
Thank you for that.
Okay, you're welcome.
Healing of the skin margin guiding you. That makes a lot of sense. Sammy, you had your hand up, and then maybe Pierre-Marie after you.
Yeah, I think these distant flaps, it's more of an art than a protocol, I think. And you could separate some of these at 2 weeks and get away with it. When we do distant flaps, I'm actually doing one for an arm coming up because the patient is not a free flap candidate for multiple reasons. What we do usually is I'd make the decision based on the wound bed. If it's a small wound bed, you have to be a bit more careful. This is a larger wound bed, so there's more room for revascularization from that wound bed, which is fairly healthy. So you can maybe get away with even 2 weeks. Just a couple of comments. One trick, if it's an older patient, maybe not pediatric, and if it's a larger flap, what you can do is delay it. So do exactly what Dr. Efren did, is basically dissect out the whole flap, but not transfer it, just tack it back down. We know the data shows about 5 days, you get a lot of vascularization and so forth, and the vessels open up, and then 5-6 days later, then transfer the flap, and then you can potentially get away with this in older patients. And then another trick that I've learned on mission trips as well, working with colleagues who do this more frequently. Some people take a clamp to the bedside, and at 2 weeks, they start putting a clamp across the pedicle more and more every day. And then that kind of stimulates vascularization. Something that I do when I do nasal reconstruction with flaps like this from the forehead, you can just in the office take a knife and just cut through the dermis, but leave the deeper tissue. And then I just cut it and then sew it up at the bedside. and then a week later I'll divide the pedicles. There are all these little tricks. But it's such a wonderful art, and this is a phenomenal result.
Thank you.
Pierre-Marie, did you have a comment?
No, I was going to talk about the clamp technique, but he just alluded to that, so that's exactly what I was going to say. One other thing that I usually do, because you want to know how that flap is going, you just basically don't cover the middle part of the flap, and you kind of look at it from day to day, and you evaluate as you go. So yeah, great work, fantastic results. Okay, thank you.
Thank you.
Thank you. So we're running a little bit behind schedule here, and I really am grateful for everybody who's been here until the very end. We could continue talking about these cases for much, much longer, but I will just take a few moments here to invite the faculty to make final comments, final teaching points and comments that you may have for all the learners who are on the line before we end the call.
I'll jump in. I just want to say these are amazing cases. You all are doing great work, and keep it up. I think your patients are really, lucky to have you all as physicians. These are great cases today. So thanks for having me.
Thank you, Lydia, and thank you for your excellent lecture, which is available for free for all who are part of this conference. You can find it on YouTube. You can find it on Sona Global Academy, and we'll have some slides talking about that shortly. Well, I think that I've certainly learned a lot from today. This distraction histiogenesis to cross-leg flaps to using these pedicle flaps. It's been a remarkable session. And as an orthopedic trauma surgeon, this is not usually my skill set. I'm blessed to have a colleague in Dr. Sami Dowlatshahi who handles all of these cases for us. But in resource-limited settings, I think we must be versatile to manage these complex cases. And I think this case presentation is not only informative, but inspiring for all of us to be able to provide excellent care for patients who desperately need it. So with that, I'll start to end the session here and just say thank you to all of the case presenters and to all of the faculty. And not just for today's remarkable session on soft tissue coverage, but for all 4 weeks that we've been together for complex lower extremity trauma. This has been one of our best conference modules to date, and we've had people from all over the world join us with a wonderful, constructive, and positive feedback for how to make these sessions better. So I would just like to thank everybody who's been involved and also the organizing team for participating in this remarkable effort. Next slide, please, Elise. I'll just make a final plug here that we are very happy to provide certificates of participation in this course to all participants who joined us for each of the 4 sessions and complete the pre and post-conference surveys for each session. So we give certificates for the entire course, not for individual live sessions. So if you joined us for all 4 sessions, we'd be happy to give you a certificate of participation in the course as a whole. So here is the conference survey. I think that the part of the team can perhaps put the link into the chat, but all folks who have registered for the conference will receive the links by email, and I'll send it out to the WhatsApp group as well. Next slide, please, Elise. We obviously love having these conversations with all of you from around the world. Let's continue the conversation. We have a thriving community on WhatsApp of providers and trainees from all around the world who are constantly sharing tough and very inspiring cases. And for those of you who would like to continue the conversation, please join us on WhatsApp. Many of the faculty who have contributed cases and discussion today are on there, and I always learn a lot from those conversations. Last plug here for becoming an OTA member. MyWin gave us this wonderful link here that we're very proud to share. The OTA is waiving application fee for those who are from resource-limited settings. Please contact Dr. Wynn and please register to become a member of OTA. You will find within the curriculum for this course, there are fantastic resources from OTA, including a great surgical dissection video by Dr. Blair, and wonderful articles. So please consider becoming a member. I'm sure you will not regret it. It's a really wonderful library of resources and a great community of people. Many of us in the faculty are members of OTA. And of course, I can't end without making a final plug for our Sona Global Academy website, where we have placed all of the free resources. Fantastic lectures available in French, Spanish, and English from our esteemed faculty members, as well as these free resources from not only OTA, but the Journal of Medical Insight, from Ostgenic, and those are all available. And IGOT, the Institute for Global Orthopedics and Traumatology, and SIGN, wonderful library of resources curated and collected for this conference. And just to end on this final slide, thank you for joining us today. It's been such a pleasure. This is one module of 6 that we have planned throughout the year. Our next conference, which was the Haitian Annual Assembly for Orthopedic Trauma, unfortunately, as Arsène was mentioning, given the political violence currently going on in Haiti, we will be postponing the live sessions. However, the virtual curriculum we will still be putting together in a form of solidarity for our colleagues and the trainees in Haiti who are really in a tough situation, but are still eager to participate in learning and be part of the community, and we want to support them however we can. And of course, all of you who have been part of this. So we will be sending out the curriculum for HAOT in April. And then the next conference we have coming up is in May on spine surgery. We have 3 excellent topics lined up for that, and please do look out for registration emails and just be part of our community so we can send those out. So with that, I'll just say a final thank you, and we hope to see you again.